Hello, everyone, and welcome to our Quick Talk series, Quick Answers to Trending Topics. Today's very important topic is on mood symptoms in children and increasing access of care at urgent care with behavioral health. I am Allison Serco, Regional Director of Community Outreach and Engagement with Hackensack Meridian Health, and will be your moderator. We are very grateful to have Dr. Thomas Priola from Hackensack Meridian Children's Health speaking with us today. A little bit about our speaker. Dr. Thomas Priola is a psychiatrist trained in child, adolescent, and adult psychiatry. He sees and treats patients within many settings of Hackensack Meridian Children's Health, including crisis cases in the pediatric emergency department, psychiatry consults for inpatient, outpatient therapy, and at the Neptune Urgent Care for behavioral health. Dr. Priola cares for patients of all ages at HMH hospitals network wide. Lastly, he is also integrated with the Child and Adolescent Psychiatry Fellowship, where he is the Assistant Program Director. The information presented and discussed today is educational in nature and is not intended to be taken as a specific recommendation. If you have any personal questions or concerns, you should speak with your primary care physician. So let's get started.
Hello, how are you doing?
Good, Dr. Priola. Thank you so much for joining us.
Nice to see you. So let's get started here.
All right. So the first question we have is, what are the most common mood symptoms in child and adolescent psychiatry?
So by far the most common that we see in children and adolescents, from young as 3 to through their teenage years is anxiety and the different forms of anxiety that comes with it. Also common ones that we generally see are depression, ADHD, behavioral conduct symptoms. A lot of the times the parents will bring the kids in for what we call external symptoms, which are things that you can observe, but then after talking with the kids, we see that there are these underlying anxiety, depressive symptoms, ADHD, and we try and work with the family. Interestingly, I think mental health issues are much more common than traditionally thought about. From age 3 to 17, we see 13% of children with some form of mental health or behavioral health condition. And then when you look at the adolescents, it's actually 1 in 5 children have a significant symptom profile.
All right. The next question is, what are some age-specific details to know about anxiety?
So speaking more generally, when you talk about anxiety for a person of any age, we have to think about what is normal versus what is pathological anxiety. Normal anxiety is anxiety that we feel is helpful. It is protective in nature, kind of evolutionarily derived. It's a way for us to be prepared to a potential threat that we might face. When we think about pathological anxiety, it's when this normal anxiety is just a little too much. And what happens is we see an impairment in the ability to respond to the threat or to the environment. Children might might not function as they have in the past. And again, it can be different for different ages. In infancy, from when children are first born, we see some healthy signs of anxiety. It's anxiety to loud noises, being dropped. There's even a reflex that we see when we bring our newborns to the pediatrician, being the startle reflex. As they get older, we start to see more environmentally based anxiety symptoms. At 9 months, they start to have stranger anxiety. They recognize that they've never seen this person before. They don't want to go to that person. They might be more comfortable with people that they know. And then toddlers, you start to see, they might ask about monsters or they don't want to sleep in the dark. As we go on to school age, That's when children are starting to think more abstractly, and they're worried about injury, they're worried about their families, natural disasters. They can have specific anxieties or phobias, such as spiders or heights. And then in adolescence, we start to see it kind of more in line with anxieties that we see for young adults and even adults, where anxiety is centered around social competence or school work performance, as well as their physical and mental health.
That's very interesting. The next question is, what are symptoms of anxiety in children and adolescents?
So I kind of um, have a list of the most common ones that we see. And it's kind of, if we think about it based on that last slide of the anxieties of different ages, we might see avoidance behaviors. And later on the list, you see school refusal. I think this is an anxiety to things that bring the children out of their comfort zone. They might not want to go to social events, or they might feel anxious about being around their friends. Clinginess. This is something that we see even in younger children, and at times it might be not to a point of needing treatment or dysfunction, but we can see children if they're at a birthday party, say they might not want to play with their friends. They might be stuck around their mom or their dad's leg, and you're trying to, get them to be a little more social with their friends, and they don't want to because of the anxiety related to it. I think as anxiety kind of worsens, we see it affecting more areas of life. They might have difficulty concentrating because they're having racing thoughts about their different anxieties, changes in eating habits. Um, for school age children, or even younger children, we see regression to earlier behavior. Sometimes it might be bedwetting or sucking their thumb, wanting their bottle again. Um, and as they start to understand their anxiety, I think we see an increased need for reassurance from their parents. A big one that I think is often overlooked is the somatic symptoms associated with anxiety. And generally what we see is headache, belly pain. Sometimes they have, non-specific back pain, things like that. It might be related to just the anxiety in general. If it's more school related, we see a lot of correlation with belly pain. With sports, if the child's having anxiety about sports, they might have this pain in their leg that can be unexplained. But if you step back and look at it, it might be a clear sign that the anxiety is leading to worsening physical symptoms.
All right. The next question, what are the most common anxiety disorders seen in children?
So again, I kind of broke it down through age. In preschool, we see the most common being separation anxiety disorder, not wanting to be away from their parents, and it can be healthy, a child not wanting to be away from their parents. I think it doesn't necessarily require treatment or an evaluation with a psychiatrist. What we want to prevent is this separation anxiety um, leading to some form of dysfunction. Maybe the child is unable to go to their preschool or kindergarten classes, first grade, elementary school. They're unable to go out with their friends, and while if they are away from their family, they're constantly asking, "Where is mom? Where is dad? Is mom and dad okay?" And that's when we start to think about what can we do to help these kids. In school-age children, we start to see specific phobias, generalized anxiety disorder, and selective mutism. Specific phobias are um, kind of being afraid of a specific thing. For some kids, it's heights, needles, blood, things like that. Generalized anxiety disorder is exactly what we think of it as. It's the constant anxiety about multiple facets of life, inability to calm the anxiety with some other kind of symptomatology associated with it. Selective mutism is kind of more in line with a separation anxiety disorder or a school refusal. where a child might not talk in a specific setting. For adolescents, we start to see more of a social anxiety disorder, concern over friendships, concern over how they're perceived by their peers. And then we also start to see the rise of panic disorder in adolescence.
Okay, the next question we have is what are the common treatments for anxiety disorders in children and adolescents?
So treatment is really multimodal for children and adolescents as well as adults. The first line of treatment always is psychotherapy. You want to understand what's going on, how they got to this place of anxiety, and how they can cope with it, using healthy coping skills to realign their thoughts and hopefully bring the anxiety down. Sometimes it also requires a social aspect where you're utilizing the family or school. You can have something like a 504 plan or just increased supports in school. You can also have community interventions. If the family goes to church and the child is having social anxiety, you can have the community at church kind of warmly welcome the child. And then for the more severe forms of anxiety, we do sometimes use medication management, even for children and adolescents. I think it's definitely a conversation to have with your physician. It's not, if you bring your child to a psychiatrist or a psychologist, it doesn't mean that they have to be put on medications, but it's a tool in our toolbox. Um, and each child is really looked at as a unique person. We have to take several factors: the age, the severe level of impairment, as well as the preferences for the child and the family in kind of which route we take for treatment.
All right. The next question we have is what does depression look like in children?
So I specifically separated children and adolescents here because I think depression in early childhood until your adolescent years it looks a little bit different than it does for older kids and adults. Very often, these children will be irritable or throw a lot of tantrums. Um, and they might not report feeling sad or depressed like an older kid does. And we think of this it got to this because they're just unable to really report, I feel sad, I feel depressed. That they're not connecting it. So they're acting out. They're, very irritable. They're having these vague complaints of belly pain or, sometimes their tooth might hurt them. And you're trying to figure out what's going on because you're bringing them to doctors. Nothing's wrong. And you really got to try and, you know, navigate these younger kids. It's a little bit of a different picture. At times, we can see some of the same symptoms. Sometimes they do report feeling sad, or um, some of the symptoms are also similar to anxiety, and you kind of have to parse out, is this depression or is it anxiety? Those symptoms being the school refusal or social withdrawal, the somatic complaints that we just spoke about. A big one for these young children is failure to meet expected weight gain as well.
All right. What does depression look like in adolescence?
So during the adolescent years, we start to think of depression kind of more as the more traditional view of depression. Adolescents are able to kind of voice their their feelings and their thoughts a little bit better. So a lot of the times we hear them say, "I'm feeling depressed. I don't want to do things that I once enjoyed." But specific for adolescents, we also see anger or behavioral changes. They might be acting out, being hostile, kind of um, experimenting with things that they didn't do before. Um, as we start to see the depression worsen, we start to see some social withdrawal, or they might start giving away their valuable possessions, questioning the meaning of life, things like that.
All right. The next question is How do you know when depression symptoms are becoming more severe?
So the way we kind of think about the severity of the depression is the level of functioning that they're able to continue to have. And as the depression becomes more severe, they're kind of lacking in things that they either once enjoyed or once were able to do. Their grades might decrease. They might not be active in sports. Their friend group might become smaller, spending more screen time. Um, a decrease in hygiene, not taking care of themselves. They might say that they feel detached or numb. And then, kind of, as we continue to worsen, we see children kind of talking about hopelessness, helplessness. Guilt is a big one because they feel like they have to kind of rely on the parents and they don't want to, so they start to feel guilty. And then, as if we progress into even more severe symptoms, it's thoughts of not living, self-harm, or suicidal thoughts. And then these thoughts kind of turn into plans and intent or behaviors.
Okay, the next question is, how do you know if your child is self harming or having suicidal thoughts?
I think the obvious answer here is talk to them. Have them, the goal should be to have your child feel comfortable being able to tell you anything in a non-judgmental kind of um, non-parental way, just being able to come and talk with you one-on-one. Uh, but specifically about self-harming and suicidal thoughts, if you start seeing unexplained injuries on your child, whether they be scratches, cuts, burns, or bruises, if they're wearing long sleeves or pants even during the summer months, if you start to see sharp objects, maybe in their nightstand drawer or in their bathroom that weren't there before. Um, if they're avoiding social situations or having cover-ups on parts of their body, this way you can't you can't see the self-harm um, injuries. And for suicide, we start to see sometimes these kids actually talk about death or suicide, question the meaning of life. Sometimes I think it's important to talk about the spectrum that we see here. And it kind of goes from a kid saying, I don't care if I wasn't alive. It doesn't matter uh, if I was dead. That's a little different than a kid saying, I wouldn't mind if a bus hit me on the way to school today. And that's even a little bit different than I want to jump in front of that bus. So you kind of have to gauge where your child is at. And obviously, if they got to this point, it's definitely time to seek professional help. Um, some of the more overt symptoms that we see is the children giving away prized possessions, saying goodbye, writing or journaling about death or suicide, talking to you about a plan that they have, or um, kind of referencing a potential plan. Uh, If your child is at that point, I think bringing them to the hospital is the safest thing to do.
Okay. I have a question that's not on here, but if your child won't talk to you as the parent, what do you suggest?
I think if your child is not talking to you as a parent and you're concerned about them, it depends on your level of concern. First of all, there's hotlines like 988 that you can call and have your child talk to them. It's completely anonymous, and I think that's important to tell children. I tell every kid that I see, when the parents step out, it's just him and I in the room. And it's not something, we don't have to tell mom and dad everything that we talk about. So it's important for the child to understand that if you do call something like a 988, that the things that they talk about are confidential. Um, I think if you're a little more concerned, then calling 911 and bringing them to the hospital. That's like the immediate, we want to make sure they're not going to do anything in this moment. If it's kind of more of a chronic thing, you just want to make sure your child's doing okay. You could bring them to the urgent care, which we'll talk, or you can call and schedule them a psychotherapy appointment. Having somebody that the child trusts and is able to talk to, even if it's not the parent, is the most important thing.
Okay, thank you. The next question is, what is the treatment for depression in children and adolescents?
So very much like the treatment for anxiety, it's multimodal in nature. Um, Studies have shown that if we look at therapy and medications and we take each of them alone, they're both effective, and some argue equally as effective to one another. And some families prefer the medication route, some families prefer the therapy route. With those studies, what it shows is that when you use therapy and medication together, if the depression is at a severe enough level, the two of them together work best. They provide the most rapid reduction in symptoms while also providing the longest treatment or the longest kind of treatment-free or symptom-free period. Outside of the therapy and the medication management, we also rely on the social aspect, and that might be family interventions such as family therapy or parent management training, community interventions, and then school interventions. And again, that could be like a 504 plan, or it could be as simple as having the kid talk to the counselor once a week or a teacher they trust. Kind of using the whole community is the best route in treatment for these kids.
Okay, the next question, what are some of the difficulties obtaining access to care?
So there's a number of different difficulties for psychiatry in particular. To just state what access to care means, it just means getting the appropriate level of care for your child at the appropriate time. Um, and there's a far range of difficulties, as I'm sure all parents who have tried to obtain mental health help have faced. To start with, there's a shortage nationally of mental health providers, and New Jersey in particular is no different. Once you do find somebody that you find is a good fit, whether it be insurance issues or location issues, then you run into long wait lists. The child might be waiting weeks or months to be able to start care with somebody. Sometimes there's just a lack of awareness. A child might be anxious or depressed, and it's been that way for so long that you kind of lose focus. And once it's time to get help, it's too late. And it's a little difficult at that time to get the appropriate level of care at the appropriate time. Um, I think over time, stigma has improved, but there is always going to be some stigma associated with mental health, and sometimes, families feel you just got to toughen up, you just got to toughen up, but sometimes they need help. And then financial barriers are always obviously a concern as well. The interesting thing about psychiatry or child psychiatry is that there is a tremendous delay in time of treatment uh, when looking at the initial symptom presentation. For mood disorders such as depression, we see a delay in treatment of 6 to 8 years. Anxiety disorders can be from 9 to 23 years. And 23 years sounds like such a long time, but I think what's important to remember is that with anxiety, these people are anxious all the time, and it's kind of just their life. And it's difficult to know when the right time to get treatment is. So if we're able to cut down these numbers and get treatment started when it's indicated, I think the prognosis for all of these illnesses greatly improves.
Okay, thank you very much. The next question we have is, what is the goal of urgent care with behavioral health?
So the primary goal, the number one goal of urgent care is to provide immediate access. It's a place that you can bring your child or adolescent, even adults, where You're able to get care the same day. No appointment is needed. You bring your child in. When they're there, they're able to get a full evaluation from a multidisciplinary team. They start by seeing an urgent care physician, they see a social worker, and then they'll see a psychiatrist for a full evaluation. Um, and then on the back end, it's not just a one-time evaluation. You're able to come to urgent care um, again if you need to, obviously, but also we have a very close relationship with a number of the hospitals where we're able to get them care with a longitudinally caring psychiatrist within a reasonable time. Usually, they're able to have an appointment within 2 weeks of coming to the urgent care. So on day one, they get an evaluation. We come up with a treatment plan. We make our recommendations, and then they're able to continue follow up within 2 weeks with a psychiatrist.
All right. And what services are there at the urgent care with behavioral health?
So as I just said, it's a full team there. They get a full medical workup. Once they're medically cleared, they come and see us. They get a full psychiatric evaluation. We do crisis therapy when it's indicated. Um, we can refer out to different therapy clinics or the hospital across the street. There's referrals sometimes that we put to IOP or PHP, which are kind of higher levels of care than weekly therapy. We're able to start medications when they're indicated. By no means does bringing your child to urgent care to a psychiatrist means that a medication will be initiated every time, but if it is needed, we're able to start it there. Um, if you have a treating psychiatrist that you're happy with, but for some reason you ran out of medications, you're unable to get in touch with that psychiatrist, you're able to come to the urgent care. We can refill with enough medication supply to last until your next appointment. Um, I think one of the bigger ones that we see recently is school clearance evaluations with fit to return documentation. After the psychiatric evaluation, if we feel the child is fit to return to school, we provide the family with fit to return documentation on the spot for them to bring back to the school. We're also able to utilize the social workers to seek information from the school if that's required, provide documentation to the school. And then again, the continued access to care, making sure that they have an appropriate level appointment and follow-up after urgent care.
All right. Our last question is, where are the urgent cares with behavioral health located?
So right now we have 4 different urgent cares that we're seeing behavioral health patients at. The one that this program was initiated in is Neptune, and I think it's the most well-known for the program right now. It's right across the street from Jersey Shore University Medical Center. And then the other 3 locations that we've recently expanded to are the Freehold location, which is on Main Street in Freehold, Eatontown, and then Clark. Um, we have the same hours for each location where we see patients from 8 a.m. to 8 p.m. on the weekdays and then 8 a.m. to 4 p.m. on the weekends. So we're open 7 days a week. You can call if you want to before you come in, but you don't have to. You can show up and we will see you with a very limited wait time. Um, the team is available. We're always there for any kind of needs that you might have. Feel free to come in. As I said, if you wanted to call, that's completely fine too. So we have the 4 locations right now, but we're hopefully looking to expand further to other urgent cares in New Jersey as well. The goal will be to hopefully cover some of South Jersey, some more of maybe North Jersey. Um, but we have to we're trying to go in a stepwise fashion this way. It's a clean rollout, but hopefully, as time progresses, we open through more and more urgent cares.
All right, great. Thank you so much, Dr. Perillo. This is such a great service. So I thank you for sharing all this great information with us today. And thank you all for taking the time to join us. Please feel free to visit us at hmh4u.org/kids to find out more information, and you can also listen to some other great educational programs. Thank you very much, and I
Thank
hope
you.
you all enjoy your day.
Bye-bye.